Hi, everyone. Welcome back to the exam room, where we explore the real world challenges and opportunities shaping healthcare today. Today's conversation focuses on one of the most overlooked drivers of patient outcomes in value based care: medication, education, and care coordination. Our guest today is Geneva Miller, founder of Equipped Healthcare Solutions. And after more than 13 years in nursing, Geneva repeatedly saw seniors and families struggling to manage complex medication regimens, fragmented care plans, and chronic disease processes, often without the education or support needed to prevent avoidable crises. Through her concierge nursing and care coordination work, she's helping families navigate those gaps while also raising important questions for healthcare leaders. Are our current workflows truly designed to support patient understanding, long-term adherence, and quality of life? Thank you so much for joining us in the exam room today, Geneva. Before we dive in, could you please tell our listeners a bit more about your journey as a nurse and an educator?
Yes. First of all, just thank you for having me. I am always excited to talk about healthcare and, education and our seniors. So, I started my nursing career 14 years ago as a LPN. I actually went to school for many different things. I was a medical assistant, but I stopped. And then I went to school for a medical billing and coding. And one of my teachers there, she said, we have a nursing program. I think that you would be a really good nursing student, but she didn't know that I had went to school right after high school. And, I was like, I'm not doing this. Let me just go ahead and work. So once I went to LPN school, that kind of started the trajectory, or it was like the catalyst for me to go back to school to be a registered nurse. And I've worked all over. I started out in a doctor's office in Pennsylvania where he gave spinal epidurals, and that was very exciting to see. I transitioned into a nursing home. I think most LPNs have worked in a nursing home. And then when I went back to registered nursing school, I worked for the Sisters of St. Francis in Pennsylvania as well. I worked there at night and I went to school during the day. And right out of RN school, I became a dialysis nurse in center. And I have done dialysis for the last 10 years up until January of 2026.
Mhm.
So my dialysis career took me to home dialysis. I have worked as a care coordinator myself or a case manager. I was an educator during COVID. So during 2020, we had to start to educate our teammates virtually. And that's when my love for education started as far as healthcare goes, even as a home dialysis nurse, because the nurses train the patients on how to cannulate themselves. And, we
Mm.
get to really get connected with the families and their care partners. And that was when I got to really learn the ins and outs of dialysis. So that was the start of it. And then I wound up in IT somehow with a program that the company I used to work with, they had a version of Epic for nephrology practices. And that's when I got to see the physician side or the internal side of how things go when we go to our doctor's appointments and how that needed a fix as well. And then my last role with the company before I started in entrepreneurship was being a provider engagement manager, helping with value-based care. And that is a very heavy lift when it comes to value-based
Mm.
care, but it does require a lot of care coordination, working with physicians, working with nurses, and making sure with the patient and their families, we help them to coordinate care and, spot those problems early so that we can keep them out of the hospital.
Mm. Oh, thank you so much for all the work that you're doing in our patients' lives. And I'm wondering when, because you and I talked previously, talked a lot about medication management. When did you
Mhm.
start noticing that there was this major gap in patient support as far as medication safety is concerned?
So medication safety, I think I had mentioned this to you before when I was at LPN. There was, or maybe it wasn't you. I may have not shared this story, but I remember having a gentleman take, oh my goodness, Dilaudid. He
Mm-hmm.
had some sort of pain. I can't remember. It was phantom pain. All I know is I think he was a veteran, and I remember having to write out on his script that he would have 1,020 pills. Now, this is per month.
Wow.
And I remember thinking, because I had surgery before, so I remember having Dilaudid IV, and that does work a bit faster. But I was like, that's a lot of pills for someone to be taking of a pain medication. And that was the first time. And we back then we would get printouts from the healthcare company showing us where the person went to get their medications. So because back then it wasn't like a lot of electronic health records, so those files would come through paper in the mail. So we would get a
Mm.
list to see, like, oh, they filled oxycodone here, or they got oxycodone filled at the pharmacy on this date, so that day wouldn't have like refill too soon. So now you can see it electronically. But then when I got into dialysis and I would do the case management, and the patients we would call them after they got discharged, and they would say, oh, the doctor in the hospital took me off of blah blah blah. And I was like, well, you need that because that's for your heart condition. You don't want to have any blood clots or anything like that. And they would say, oh, I didn't really know that. And I was like,
Mm.
well, did you tell them that, you were taking this for 1, 2, and 3? And they were like, oh, I didn't know that was what it was for. So during the time when I was a case manager, I started to realize that either my patients didn't know what they were taking their meds for. They were given a diagnosis, and then they were told, take this medication while you eat, but they didn't really grasp everything. Because remember, when you're given a diagnosis, I think like the grief process starts. So now I'm in
Mm.
denial, right? Or
Mm.
now I'm angry, or I'm trying to bargain. Well, if I eat right, then the disease process will go away. So they're not really listening to everything. So that's why education happens over time. Like we have to repeat things over and over and over and over again, for them to really, kind of grasp it. But that also depends on the person's health literacy. So if they
Mm-hmm.
only went to fifth grade education, then they may not understand what I'm saying. So I have to have like a psychosocial conversation, and maybe the social worker is involved, because sometimes it's a touchy subject to talk about, like reading. That's another thing. When I was in center, I was surprised at how many people like don't understand reading, or can read. It's like, where do I sign? So when people start to ask me where do I sign, that's an indicator you don't know where it says sign here. Not trying to embarrass anyone, but when we think of healthcare, we're dealing with people on a whole another level, and they have different learning experiences. Like they have different ways of dealing with healthcare. But for me, it started as an LPN, but it got more prominent when I started the care coordination, and I realized that a lot of people don't know what they're taking meds for.
Right. So you said something that I don't know, it's heartbreaking, but I think it's really eye-opening as well, that the grief process starts with the diagnosis. I guess that's something that I never really thought about in that specific way, but it's so true. And I'm wondering if this feeds into, when our patients are leaving the office, they're leaving the clinic, they're not fully understanding the disease process, or when we start to feel all of those emotions, scared or worried or angry, our brains just kind of shut down. When patients leave the clinic without fully understanding, what are some things that we can do? What can our listeners do that are leading health centers and trying to implement additional things that they can do to help their patients with these situations?
hmm I think it's going to come with a huge mindset shift, and it's also going to come with a, like, what's the heart of your practice, right?
Mm.
I took a class with a physician who was the head of a nephrology group, and one of the things he taught us was to ask the physicians, when we go in and talk about value-based care, is like, what are your goals for your practice, right?
Mm-hmm.
Or what do you think your patients feel when they come into the front office? What do you think your patients feel when they leave the office? All of those things that we may not think about, because the first impression is a lasting impression. So let's say we come into the office, you're my doctor, Dr. Windsor, I meet you, and you're like, you have stage 5 kidney disease. You're going to have to go on dialysis, in 15 minutes, because that's the average appointment time. We got 15 minutes. So you
Yeah.
have to explain the disease process to me. I now have to understand if I can grasp this, because let's say I just went to high school and then I went to work, right? I learned a trade, and not that there's anything wrong with learning a trade, and it doesn't make anyone better if we get master's degrees or if I have a doctorate. There's
Mm-hmm.
still things that we don't know. So the timing
Yes.
of the education matters, right? So I
Mm-hmm.
give you 15 minutes, and then what happens after that? Do I have a care coordinator who calls my patient back and says, hey, I know you came in on Monday, today's Wednesday, I'm just calling in to check and see if you have any questions about what was discussed. Do you understand what was going on? How are you feeling, right? Is there a way that we can help your family members understand your disease process so that they can help you, or they can better explain it to you? Because with Medicare or Medicaid, I just found out that the home care company can only send like a companion or a CNA out with a patient one time paid, right? So let's say you have 4 other disease processes. So your aide can only go with you, especially if your children are working, your aide can only go with you to one appointment per month.
Mm-hmm.
This is not per week. It's per
Wow.
month. And I have 4 other doctors that I might have to go see. So now, sometimes with kidney failure, your mind, your cognition is not there until you start to get all of the toxins out. So now I really can't understand, because of the disease process. I hear you, no matter my level of education, but I might not be able to retain it, because I'm either going through denial, or the disease process is affecting the way that I think. I even think about
Mm-hmm.
menopause, because sometimes we be
Mm-hmm.
going through premenopause, and then I feel like I'm going here, there, and everywhere. So there's a lot to think about when we think about our patients. So it goes back to the heart of it. As a physician, what do I want my patients to know me or my office as? Well, I got this diagnosis, nobody ever called me back, so now I'm not going to return, and then I'm going to crash into dialysis, or my family member might have a heart attack. So let's go back to the start of it. Do I have care coordinators in my practice? Even if it's one, right? Maybe you're a
Mm-hmm.
small practice. Even if there's one person and they do part-time, I don't know. Do we have educational materials that I can give to them? Will they read them or not? We don't know, but at least we can check in. Do we
Mm-hmm.
have any technical tools? Is there a text message that's sent out that says, we're thinking about you? Because once somebody feels seen, then it's like, okay, they care about me. Will we have a lot of time to spend 2 hours with each patient? Maybe not. But even a text message to someone, right? If they have an emergency contact, your mom, was just here today, 123, can we help you with something? Give us a call back. I think we have to
Mm-hmm.
get the person back into healthcare. We're so used to moving so fast that we take the people out of it, and it's like, here, this is what you have. Go. I'll see you in 3 months. And they're like, I'm not going to change my diet. I've been eating like
Mm-hmm.
this for 40 years.
Mm-hmm.
So I think we have to come back to the person, um, if that makes sense.
It absolutely makes sense to me, for sure. I think that customer service is something
Mm-hmm.
that every other business on the planet really prioritizes, and in a lot of ways in healthcare, I think we're failing to meet the mark with the customer service part of healthcare. I know, I had a thought when you were talking. My mom was diagnosed with prediabetes, and my stepdad usually goes to the appointments with her, but I was talking with her afterwards, and I'm like, okay, well, what did the doctor say? The doctor said I can't eat anything anymore. There's
Mm-hmm.
nothing.
That's all she heard. I can't.
I can't eat anything that I like. And despite all of my efforts and the doctor's efforts to change that way of thinking, she hardly eats. So getting her nutrition with this very set mindset of like, well, I can't eat anything I like anymore. I'm wondering, in your experience, what are some other consequences that you're seeing to patients leaving the clinic, not understanding their medications or disease processes?
hmm So rehospitalization. So it's either going to be rehospitalization on the low end, where, like you said with your mom, well, I'm not eating. So if it gets to low blood sugar, right? Does she know the signs and symptoms of low blood sugar?
Mhm.
And then without knowing that, whether she's out and then God forbid she passes out. So even though the things that she likes may have been things that would drive the blood sugar up, there is a way that we can try natural sugars, right?
Mhm.
So then
Mhm.
my nutritionist comes into play. Again, depending on age, our seniors are not on TikTok. So they're not researching,
Mhm.
diabetic friendly desserts, or things that I can eat as a diabetic or pre-diabetes. How do I eat? They're not doing that. So how do we reach them? Is it a
Mhm.
commercial that they see while they're watching their shows? Is it something at the community center? Maybe they go to community centers. Again, are we educating their grandchildren? Hey, grandmom, I just found out about 1, 2, and 3. Let me come and make that for you. But again, it's timing. And America, I'm not sure who else is going to listen around the world, but in America, we're going, going, going.
Mhm.
So are we sitting down with our seniors and saying, hey, what did you do this week? I saw someone the other day. I was at Hobby Lobby, and she was with, it was either her grandmother, maybe it could have been an aunt, but they were just walking through the store, and it just made me smile because, and she was younger, in her 20s probably. So I'm like, a lot of people, either teenagers or 20-year-olds, how many of them are hanging out with their grandparents? But
Yeah.
those are the people that we can reach. And it's like,
Mm.
oh, grandma was diagnosed with this, how can I help her? Again, it's the education piece. So I'm teaching the younger children who are caring for their grandparents, or helping them, because once our parents get sicker, now it becomes a burden as a caregiver, right?
Yeah.
And not that a burden is just a word, but it is very stressful to take care of anyone sick. I don't care if it's a baby, a dog with cancer.
Mhm.
Like, sickness is sickness, like disease
Mhm.
is disease, all any way you look at it. So
Yes.
back to your original question. So the hospitalizations, I think, on the low end, and then on the high end, some people who don't understand their disease process, they're going to keep doing what they're doing, and then they're going to end up in the hospital as well. Now theirs may be even more extreme, because again, take it for diabetes. If I don't stop eating a certain way, or I don't change my diet, or even if I don't take my insulin, could that lead to an amputation? And then guess what? I have a 2-story home. Now I can't get up my steps. Do I have
Mhm.
long-term care insurance? Are my children able to put me in their home, but they have stairs as well? Who's going to get me a wheelchair thing to go up the steps?
Mhm.
These are all things that we don't think about, and it's a horrible cascade, because I met with a family last week, and the mother was very young. She had a stroke, and all of the children have 2-story homes, and there's no insurance. So how will she go into a home? Right? How is she going
Mhm.
to get someone to come in and even do companion care or help with bathing or showering without insurance? We're going to pay out of pocket. Who's going to pay out of pocket every day for a caregiver to come in?
Yeah.
So I think when we don't have the education foundationally, it's going to lead us back into the hospital, and then the hospitals don't want them to keep coming back, because then they don't get paid.
Mhm.
Once, if you're
Sure.
discharged in and out, then there's, at a certain point, they're not going to get paid for that care. That's why our patients are in and out of the hospital very quickly, and for
Mhm.
safety reasons, with the germs and different things like that.
Are there things that you're finding that most patients and families most commonly misunderstand?
I think that most commonly we think that if we take the medication, I can still do the same thing I was doing before I was diagnosed. And I
Mm.
think that's how the disease process continues to linger or it gets
Mhm.
worse. Because
Mhm.
you can, let's say you have diabetes and you take metformin, but if I'm not eating properly, then my sugar levels are still going to be out of range. It's still going to affect my eyes, right? It's still going to affect me having numbness and tingling in my feet. So just the common thing of, I think a lot of us think that if I take the medication, it's going to make the disease process better. But we still have to make a lifestyle modification, even if it's 10%, even if
Yeah.
it's 20%, right? So that your body can start to compensate with the medication. Because I'm not all, some people, we have functional medicine doctors right now, which I love, but there are some people who are not going to be able to change the way that they eat, right? Maybe
Mm.
financially they can only buy what they can buy. But if
Yeah.
I can teach them, well, maybe we swap this sugary drink out for water this morning, right? And maybe you try that for a week. Just because we have to meet people where they are. I know a young lady who's a culturally competent nutritionist. So she's not telling everyone, well, let's take out the foods that you love culturally. How
Yeah.
can we change them just a little bit so that your body can start to work with the medication and heal itself? And then
Mhm.
gradually over time, we take you off the medication as you gradually start to have more healthier habits. So we don't want to be naive, but we also want to meet people where they are.
Absolutely. I think I don't know if you're finding this, but in my experience with just like family, friends, those kinds of things, that there's a thinking that, well, okay, if I'm on metformin, let's say,
Hmm.
or Ozempic, and my sugar is still continuing to go up, well, the doctor will just increase my medication. Right.
Hmm.
Instead of thinking about those suggestions that you just gave about, well, what other things can I do to help manage my blood sugar so that I don't have to take more medication? Like
Hmm.
start thinking about those kinds of things. And I think we're one of the countries that have the most prescriptions of
Most.
anywhere in the world. But,
Sure.
we just think, oh, well, and we're in this very fast-paced environment, like you said, so we're like, "Well, we can just take a pill. We'll just take a pill, and
Mhm.
then I can
And
go
I
on
think,
about my day."
too, food, a lot of the disease processes unfortunately have to do with food or like the
Mm,
nutrition side of it. But we also have to remember that food is a coping mechanism. So
mhm,
now you're trying to take away the way that I enjoy my family, right? Or you're trying to
yeah,
change the way that I celebrate myself. Or, I had a bad day, I want to go and get some ice cream. Like, it's more a social or psychosocial than we seem to think. And that's why a therapist. Now, how many people want to go to talk about things, right? There,
yeah,
it's more than just we're taking something away. And when I was in dialysis, I realized a lot of people were angry because we were telling them, oh, it's hot here today in South Carolina. It's going to be probably 90 degrees. So now I'm telling you that you can only have 16 ounces of water for the
mm,
day because you're not urinating and it's hot.
mhm,
So how are they to now compensate? It's like I'm thirsty. I can't eat the same things I want to because the foods don't taste well, right? And I can't eat too much of this because the salt intake is going to make me hold on to water, and then I don't want to have a heart attack. So we're taking so much away from them, and we don't want to, but in order to help them get back to a stable place, we have to do it at first. So it's also now I need a therapist because I'm angry. I know I don't want to come to dialysis and I don't want to
mm,
talk to you. And if
mm,
you come here and talk to me, I'm going to shut down. So I'm just
mhm,
here because I have to be. And then the education, we don't get to them anyway.
mhm. Absolutely. I think what you said about timing is so, 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 so important. In your opinion, why do you think it's important for value-based care health centers to know and understand this?
Always understand the education piece. I know that they should understand the education piece because the cycle is always going to continue. If our patients, even if it's 10%, if 10% of our patients don't have a successful outcome, people, let's think about when you go to a good restaurant. I'm sure we having a conversation on Monday, and you're like, Benjamin, I went to this place and it was so good. I know you like guacamole. I know you like these tacos. I think you should go there and try it, right? Because I had a really good outcome. So we think about that, like you said, with customer service, and I'm still talking about food, forgive me, but with Chick-fil-A, always 9 times out of 10, 10 times out of 10, it's my pleasure. So even if the chicken is getting bad and it's changed over time, I'm still going back because they always have good service. I don't think I've
Uh-huh.
ever been to a bad one,
Me
right?
neither.
So we're
Nope.
telling, even with healthcare, I would say, oh, I went to this place and you could go to this doctor because they take their time, right? Somebody is going to give a review to a family member, because if we think about genetics or diseases, and I don't always believe that if my grandmother had it, I'm going to have it because I don't want it. But
Mm-hmm.
if we have a family that says, oh, I was diagnosed with diabetes, but I went to see Dr. Winsor and she did 1, 2, and 3. Her nurse called me, twice a month, and they checked in on me. And guess what? Now I don't have to take my metformin because I've learned how to eat in another way. So
Yep.
the education piece is very critical, and we need to understand this in value-based care, because when our patients don't get the right outcome, then you get penalized. So do you want to continue to get penalized for a system that you may feel like you're being forced into? Or can we just take 10% of our whatever the income or the budget is for the year and say, look, we're gonna put it to this amount for education. Just try it. Well, what are we going to lose? If you're already being penalized, you're losing money anyway. So let's try and use a little bit of that to help the patients. Just try it. The only thing we could do is either have a data point and it's like, oh, well, that didn't work, but what did work?
Mm-hmm. Yeah. Because even when we're learning what didn't work, we're still learning something.
So it's not a failure. And I
Yeah.
think, again, we're used to thinking, oh, well, if I failed at this or I didn't pass this, I didn't do well. No, you did. You just found out what didn't work. So now
Yeah.
we're not going to do that again. We're going to
Absolutely.
move forward.
Thanks for joining us in the exam room for this important conversation with Geneva Miller on medication education, patient understanding, and the role of care coordination in value-based care. In today's episode, we explored why patients often leave appointments overwhelmed, how health literacy impacts outcomes, and why healthcare systems must move beyond simply handing patients information and hoping for the best. In our upcoming episodes with Geneva, we'll continue the conversation by diving deeper into medication reconciliation, the hidden costs of poor patient understanding, caregiver burnout, and practical strategies health centers can implement to improve communication, adherence, and long-term outcomes. You won't want to miss what's next. Be sure to subscribe to the Exam Room podcast on Apple Podcasts, YouTube, or wherever you listen to podcasts. And if this episode resonated with you, share it with a colleague working to improve patient care in their community. We'll see you next time in the Exam Room.